Dr. Grieff is going to be presenting from Rutgers Robert Wood Johnson Medical Center on initial postoperative visit absenteeism being associated with worse amputation-free survival after tibial angioplasty.
Hi, my name is Anthony Grieff. I'm one of the vascular integrated residents at Robert Wood Johnson. I'm going to be presenting initial postoperative visit absenteeism is associated with worse amputation-free survival after tibial angioplasty. I have no disclosures for this presentation. So tibial revascularization is often performed in the setting of critical limb ischemia or tissue loss. Close patient follow-up is essential in the early postoperative period for monitoring worsening gangrene and ischemia in these patients. For that reason, current SVS recommendations include 1 month surveillance post-intervention followed by surveillance every 3 months and then 6 months thereafter. Loss to follow-up has been identified as a risk factor for worse outcomes across multiple vascular procedures. Therefore, we wanted to evaluate the role of follow-up and its risk factors against outcomes in patients undergoing tibial endovascular procedures. We performed a retrospective single institution chart review. Patients underwent first-time therapeutic endovascular tibial revascularization between 2014 and 18. This was at times in conjunction with proximal endovascular procedures, but was always the first-time treatment for the tibial section. Major outcomes were identified as death or amputation-free survival throughout the study period, and patients were followed for as long as greater than 30 days post-operatively up to 36 months. Patients were further categorized by follow-up periods, which were less than 4 weeks, meaning the immediate post-operative intervention period, short-term, which was less than 6 months, or long-term, which was greater than 6 months. In total, we had 89 patients who met criteria for our study. The predominant majority were Rutherford 5 and 6, meaning they had some degree of tissue loss. As high as 86% of the total population was for tissue loss. We found no differences as far as ethnicity. Regarding comorbidities, there was a strong trend for all comorbidities to be expressed higher in the patient that did have follow-up, which is consistent with other studies which have shown that more comorbidities are patients that are less naive to established care are more likely to follow up. However, for our study, these were not statistically significant except for diabetes, which was likely due to our patient sample size. Regarding procedural characteristics, the primary amount of patients underwent either balloon angioplasty or stenting, with the 15% undergoing atherectomy. Regarding overall follow-up, 84% of our patients had some kind of follow-up within that 36 months, meaning 16% had complete loss to follow-up during the study period. Regarding follow-up within the immediate post-intervention period, we had approximately 39% of patients follow up during that 4-week period. Regarding major outcomes, 17% underwent major amputation, whereas 9% had a mortality during the follow-up period in total. For that reason, we further evaluated patients who followed up stratified by compliance in the post-intervention period. There was increased compliance with all patients that were previously known either in wound care or in clinic. There was also a trend that patients that were employed tended to have poorer follow-up than patients that were non-employed. When you look at follow-up based on Rutherford CLI classification, in the dark red you can see the patients that did not attend that first post-operative visit compared to the longer visits, whereas in the light pink you can see those patients that did attend. You can see a clear trend that with patients that did not have tissue loss, meaning that Rutherford 4 or below, they tended to be much more absent from follow-up at the earlier time points. When you look at patients that were Rutherford 6 and even 5, you can see that there's a clear trend that patients tended to have better compliance or attendance with these post-operative visits when they did have tissue loss. So thus far, there were no difference regarding ethnicity in our single center cohort. Patients who are non-established or actively employed trended towards poorer compliance at less than 4 weeks follow-up. Patients with tissue loss or more medical comorbidities tended to have better post-operative visit compliance. But what are the risks of missing early follow-up? So when you look at all of the patients who attended follow-up compared to all of the patients that were compliant and attended that first post-operative visit, you see some stark contrasts. So in total, we had 61% of all patients following up within that first 4 weeks. When you space that out to greater than 6 months, it's also 63%. Now, when you look at those patients that missed the first post-operative visit in the two columns on the right side of the screen, you can see that that attendance plummets from 80 to 26% and 63 to 31%, which is suggestive that that first post-operative visit is either a marker for patients that are going to be compliant with further follow-up or a significant place where possible intervention can be in order to capture some of these patients that would otherwise be lost to follow-up if they don't establish care within that immediate post-operative period. Regarding outcomes, when you look at 36-month major amputation rates, our overall rate was 17% in the total population. But again, when you stratify it based off of that population of patients that had no immediate 4-week follow-up compared to those patients that did have immediate follow-up on the far left, you can see that that amputation percent drops from 26% in the non-post-intervention compliant patients versus 11%. Which suggests to us that it's really essential to get that patient involved in that early postoperative period in order to monitor for ischemia and other signs of tissue loss in order to really reduce that amputation rate. Further going forward, when you look at the Kaplan-Meier survival curves, you can see a clear difference between those patients in the light blue that missed the 4-week follow-up appointment versus those patients in the dark red in the top trend that did follow up in that less than 4-week period. Therefore, in conclusion, absenteeism from the first postoperative visit within 4 weeks is associated with further absenteeism for postoperative care and worse amputation-free survival. Ensuring close immediate postoperative follow-up is essential to improving outcomes in this at-risk patient population. Thank you. Are there any questions?
Thank you, Dr. Grieff. This is clearly an important signal that you're picking up. As we're waiting for questions from the group, my question is, how do you tweeze out compliance with functional dependence? For example, if someone's in a skilled nursing facility, they don't have much control over getting to and from the appointments, or if they were lost to follow-up, they had a stroke or some other social emergency or some other issue that was making it difficult for them to follow up. So there are patient issues and then maybe patient health issues or some other categories where you could further, a topic for further research.
Yeah, I mean, I think that's the exact crux of the point. So, in our institution, we take care of, at least our CLI patients are generally often going to rehab facilities. They're often dependent on family members, and they do absolutely have big social issues. I think the key point and something that we're noticing is that a lot of our patients get shunted to some of these rehab facilities, because they're getting CLI treatment from us, but they're really in the hospital because they're getting, TAVRs, they have heart failure, they have CHF exacerbations. And our issues of what we're kind of seeing is that those patients that often get lost to follow up on that early postoperative visit, they kind of get outside of that window of where we can do meaningful things to intervene as far as limb salvage. So, I'm not quite sure how you would tease out kind of the differences. That's certainly something we can look at more in the future, but the real thing is that I think we need to be more aggressive on our end on probably really trying to get better patient buy-in, better family buy-in, and really getting better compliance from some of these, assisted and, post-hospital care facilities in order to get these patients in the clinic.
Thank you. I think Dr. Lowe has a question.
Oh, yeah. So I think some of the questions looks like they're being popped up as well. I think we're all kind of running in the same vein, which is the way we see it is there's a lot of factors here. Socioeconomic status, transportation issues, lack of education, money, system factors, were they given proper instructions for follow-up, bias, even a lack of just a discharge plan. So, and I think Jeff Syracuse brought up some of that in terms of just people having a harder time showing up for their appointments. So given all these factors, I think it would be tough to tackle them all, but what do you think are your tops here in terms of what you're thinking is going to be your main drivers for this poor follow-up, and how do we move forward?
I think that internally, one thing we've been trying to do is we've been trying to schedule these patients before they're leaving the hospital so that they have established follow-up. So that way, when they're leaving the door, we can say to the rehab facility, or we can say to their family members, or really the patient, that, we want you at this time, at this location. And I think that's one of the benefits in some regards to some of the virtual follow-up is we're located in New Jersey at the moment. We're not seeing patients live in the clinic for the most part, unless they're immediate post-operative visits or in some cases new patients. So being able to at least have phone follow-up or have video follow-up, ideally with some of these patients, I think is a big benefit to potentially getting better compliance. A lot of these people don't necessarily have transportation or have jobs and can't quite make it to the hospital, but most people can find time to have a video call or things like that. So I think potentially some of this change in virtual could be a tremendous boon for really maximizing at least that early follow-up, seeing how people are doing at 2 weeks, seeing if they've had an improvement, seeing if they're noticing that there's purulent discharge from their toe, and we need to tell them maybe they should come to the hospital and get checked out. So it's I think anything we can do to get early follow-up on these patients is critical.
I think, go ahead, Max, if you have a question. I know you had jotted down something about how many patients died during the follow-up period. Another question I think had popped up from Randall DiMartino, similar vein. It was more diplomatic about how he stated it. How was vital status verified to be sure they're eligible to follow up? So obviously these patients have high mortality. Did you call through the Social Security database to figure out who actually wasn't alive anymore?
So 86% of our people followed up within 36 months. So we have good tracking, I think, overall of the data set. And that's looking at the entire hospital-wide network of several hospitals. So I think we have relatively good capture of it, at least when people were coming into the hospital for other times and had mortalities in the hospital. Obviously, we're going to be underestimating mortality for sure. We did not query the Medicare database for this one to see, to confirm mortality. I can tell you that of our groups of patients that did follow up, if you look at those people that followed up within 4 weeks and those after, the raw numbers of mortality are about the same. It was 4 patients out of 40 that died within the study period for those that followed up in that first 4 weeks, and it was 3 that we tracked who didn't. So I'm sure those numbers are probably higher in actuality. But I think it would certainly be something probably meaningful to query that database going forward. But yeah, it's definitely underestimated.
Yeah, so I'll just comment from our institution. This is, I live on Long Island, so it's not exact. It's a pretty affluent area, but I think that we still have issues with compliance, and the patient population that is retired, obviously living on sometimes a Social Security salary, definitely makes it difficult to be able to, to have funds to travel back and forth. What we found effective, number one, is something along the lines of like a nurse navigator to track these patients down and call them to check in on them, and because someone calls after the operation, but also to remind them of their appointments, to establish that rapport so they feel the need to come. They really understand, I guess, how critical this entity or this disease process is for them, because sometimes they don't think they really understand where they're headed, and that presents a problem. And I will even say that, sometimes I think it comes better from, my team, my nurse practitioner team, myself, as opposed to the residents, which may or may not offer kind of what I would consider, always the most concise set of instructions. Okay, so I think those are all the questions. I'm going to offer my final thoughts, and then I'm going to turn over to Max for his final thoughts, and then closing messages and stuff. But I want to thank all the presenters for coming out presenting today. Excellent talks, outstanding job by everybody. I think it was an exciting session, great topics. I like how the topics were kind of spread out over a bunch of different areas. So hopefully a little something for everybody. And I hope everybody in the audience felt the same way. Max?
Thank you all. And this scientific session really highlights the role of vascular surgeons as the vascular specialists. We're talking about loss to follow-up, comprehensive care, we're talking about trauma, we're talking about atherectomy and office-based labs. We're talking about racial disparities. We're talking about new techniques for reducing autologous blood transfusion. I mean, it was really in virtual examinations, symptomatic carotid stenosis. We really ran the spectrum here. So thank you all for the excellent presentations.